Good afternoon and welcome to our webinar with Professor Gavin Giovannoni. MS Ireland are absolutely delighted to host this webinar. So normally at this time of year we would have our national conference and our AGM, but obviously due to the COVID-19 pandemic we've had to move our activities online. So something that was very important to us is that our community members were still provided with information from experts, and in an effort to do that we have asked a series of speakers to join us in webinars to ensure that you are given the information that you need. So over the past few months with the COVID-19 pandemic, we know that a lot of you have had questions and there have been a lot of changes in the information that's been put out. So as we've learned more, we have edited and updated our information, and all of that is available on our website, www.ms-society.ie. We would like to just thank Novartis for supporting this webinar for us this afternoon. And we have joining us Professor Gavin Giovannoni. Professor Gavin Giovannoni is a Professor of Neurology in the Blizard Institute, Barts, and the London School of Medicine and Dentistry, Queen Mary University of London, and the Department of Neurology in Barts Health, the NHS Trust. So he is a leading expert in MS, and we've been definitely following Professor Giovannoni's writings over the past few months in relation to MS and COVID-19. We're absolutely thrilled to have you here. Thank you so much for joining us. And with that, I'm going to hand you over to Professor Giovannoni.
Thank you. Thanks for inviting me. So I'm just going to share my screen and hopefully you can see my slides, and I'm going to start. Okay, so I've got given the brief about updating you on what we have learned from people living with MS who have become infected with coronavirus, and I'll give you some insights as we are getting data in almost on a weekly basis. So some of the things that I'll be discussing may be out of date by next week. So that's what you've got to keep in mind, the database and the evidence base that's emerging from people studying this is really changing on a rapid basis. Just to say, I've got a number of disclosures because I will be discussing certain disease-modifying treatments. So you need to just remember that I have been involved in quite a few clinical trials, and I sit on the steering committees. That's the committee that designs and runs these trials for quite a large number of pharmaceutical companies. So I just wanted to put the scene by just going back one step and just say where we were getting to before COVID broke, because COVID's really disrupted the way we manage MS. And I think, unfortunately, it's probably going to take a bit of time to get back to where we were before COVID-19 broke. And I always put this particular picture up because this kind of represents where we want to be with MS. So this is actually a hand of somebody with what I would call end-stage rheumatoid arthritis hand. This is an end organ in the hand. It's been so damaged that, as you can see, that hand is not functional. The joints have been destroyed. There's lots of wasting of the muscles, and that hand is really not worth anything in terms of function. And you can see on the X-ray here how damaged it is. Now, the good thing about the rheumatologists is that they realize that treating the disease, the inflammation in the joints, very early and very effectively would prevent that from happening. And they've done that. If you follow any of the rheumatology or the rheumatoid arthritis field, you'll know that the need to do joint replacements or replace the joints in RA now in rheumatoid arthritis has dropped massively. It's down by about 90% or higher in certain parts of the world. And that's despite the rheumatologists having the option of actually replacing joints by giving artificial joints. But anyway, they pioneered this strategy of treating to a target to try and suppress as much of the inflammation in the joint as possible. And we've kind of adopted that in MS, and we've tried to do exactly what they've done. We've tried to intervene earlier and as effectively as possible, and hopefully we will change the trajectory. In other words, fewer people will become disabled and fewer people will need walking sticks and wheelchairs. Now, despite the rheumatologists leading the way, you may or may not know that the neurologists have been a little bit slow in adopting some of the treatment principles that have emerged from their field. But the question I'm always asked, is this working? Is intervening early and more effectively actually changing your outcome? And it's no doubt it is. And we have 3 therapeutic strategies. We have on the left here the old conventional step care approach, where you would have watchful waiting and you'd move through the different drugs at a very snail's pace to get to the most effective therapies. And it would take literally decades to get to the most effective treatments, because you would spend potentially 3 or 4 years trying out interferon beta, and if that failed, you might have to go on to Copaxone or glutaric acetate. And when that failed, you went up higher to a new treatment before you got to the most effective treatments. We don't use that anymore. Nowadays, we have what we call rapid escalation. We give you one shot at what we call a platform or a first-line treatment. If you fail that, and we usually assess that literally in 6 to 12 months, you move to the next tier, and you get to the top tier literally in 3 or 4 years rather than a decade. Or a new approach is what we call flipping the pyramid. And that term refers to, forget about trying the lower efficacy treatments, putting you on the most effective treatments first line. And that's also a strategy that was pioneered by the rheumatologists looking after people with rheumatoid arthritis. And so prior to COVID-19, I would say in our center, about 40% of people were getting the pyramid flipped, and 60% were going through rapid escalation, and we'd stopped using the conventional step care approach. And the question is, are we making a difference? So let's just compare these 2 approaches. So this is actually a figure. I need to go through it a little bit carefully with you so you understand what it looks like. This is actually called a survival curve. In other words, if you look on the left here, this is the probability of reaching a disability score of 6. Now, 6 to somebody with MS means needing a walking stick, a walking aid. And if you look at the top over here, in those blue and green, this is before there were DMTs available. And if you look, 80%, so over 80% of people, by the time they were 65, needed a walking stick. Then we had, in the next time periods, from about 2000 to 2010, we had the launch of what we would call the injectable treatments, interferon and glutaric. And now you can see about 65% at 65 need a walking stick. And now we've got the new era where we've got more effective treatments, and you can see the high, nowadays it's dropped to about 25% with the new treatments on needing a walking stick. So this is just an example from one center in northern Italy where we've actually been able to show with time that the prognosis or the outcome using something as simple as counting walking sticks is been changed by our treatment. So I have little doubt that our more effective therapies are making an enormous difference to outcomes. So I want you to be aware that we are making a big difference. Also, what's important is the time to get on to a treatment makes a big difference. And so this is also what we call the survival curve. And this is again proportion, so that's 90%, 80%. And you can see if you get onto treatment within a year, okay, 90% of people are stable. If you get onto it 1 to 3 years, it's about 85. And if you wait for more than 3 years, it's only 75% are stable. So, and this is another little message coming through from our data, is that the quicker you get onto a treatment, the better. And what about the thing that people are most scared of is developing progressive MS, secondary progressive disease, if you have your relapse onset disease. In other words, if you're considered to be relapsed and remitting. And yet we're seeing in an international database people with no treatment versus people on glutaric or interferon, injectable therapies. And you can see that this gap between them is a treatment effect. So with no treatment at 10 years, over 50, about 55% of people were secondary progressive. Then with treatment, that drops to about 40%. Not big, not a very big difference, but when you start going on to the more effective therapies like fingolimod, natalizumab, or Tysabri, alemtuzumab or Lemtrada, you can see there's a major difference in the proportion. We're dropping down at 6 years now to about 35%, and on near about 20%. So what you've got to realize, and in fingolimod it's about 10%, but what you've got to realize is these databases are biased. So for people to get onto natalizumab or alemtuzumab, they tend to get their second, third, or even fourth line. Whereas fingolimod tends to be a second line agent, and in some countries it's actually used first line. And so the fingolimod patients look like they're doing extremely well, which they are doing, but they're kind of different populations of people with multiple sclerosis and those getting onto the most effective therapies. So I think the message is we're not only stopping people with MS becoming disabled, but we're also stopping them being classified or developing secondary progressive disease, or reducing their chances. So our treatments are making a big difference. Now, forget about the conventional step care. What about the two strategies? Rapid escalation, in other words, starting on a first-line treatment before moving up, or flipping the pyramid and starting on the most effective treatments first line. And there's just been a paper from the international database called MS-BASE showing it's making an enormous difference getting onto flipping the pyramid. So this is actually now the first graph up top here is from the beginning of the treatment. In other words, getting onto it when you get put onto the treatment. And you can see people who get onto early treatment, okay, do exceptionally well. This is what we're using as an outcome here is time to worsening, in other words, disability, compared to people that get onto it late. And I call this daylight between the two curves, which shows you there's very little doubt in my mind that flipping the pyramid really makes an enormous difference by having to go through a ladder to get onto the treatments. From disease onset, you can see how much it is. And then after 6 years, there's no daylight between these curves anymore. They're overlapping with each other. So the message from this data is getting onto high efficacy therapies as early as possible in the course of the disease makes the biggest difference to people with the disease. Having to wait to get onto the most effective therapies actually reduces your chance of benefiting from them. And so that message we've been trying to promote prior to COVID-19 people need to be reminded of this. Even now, and the reason why I'm saying that is because during the COVID-19 pandemic, a large number of neurologists and healthcare professionals have been advising us not to go on to the most effective therapies first line because they're potentially putting people at risk of getting severe disease and dying from the coronavirus infection. And I'm going to show you that's not the case. So I want to actually say what we should be doing is practicing what we've learned prior to COVID-19 and going back to those more effective therapies first line. And this is probably the best data that's been published. So this is actually from the large Italian database. And the reason why it's the best data, because the Italians, as you know, had the biggest number of COVID-19 cases with their first wave. And they were about 6 to 8 weeks ahead of everybody else. And they were able to put their register in place to collect all the data from their patients. And what they showed is that people with multiple sclerosis who developed COVID-19, who were on interferon beta, and possibly glutaric acetate as well, did better than people in the general population or people on dimethyl fumarate, which was their reference drug. So they actually had a better outcome. So they had about a 50% less chance of getting COVID-19. And the reason for that is interferon is actually an antiviral agent. On the other side of the coin, people that were on ocrelizumab or Ocrevus, so this is a new therapy, had about double the risk of getting COVID-19 compared to patients on the other DMTs. Okay, and there was a suggestion that people on Tysabri may also be at a slightly increased risk, but it wasn't what we call significant. It was just a trend. Okay, but what's important is people on the other drugs, alemtuzumab, fingolimod, teriflunomide, cladribine, and dimethyl fumarate, okay, we had no increased risk relative to the general population of getting COVID-19. So I think this is very, very reassuring. And even the patients who were on ocrelizumab, although they were at twice the risk of getting COVID-19, they don't appear to be at increased risk of dying from the infection. They seem to just get the infection and a slightly higher chance of having to go into hospital. But at the moment, we haven't seen a signal to suggest that they're more risk of going into ITU and having to be put on a ventilator. So I think what this data is showing, and this is not the only data out there, there's now data from other databases, from Sweden, from Iran, from Germany, from France, and the US, that is confirming these findings. So I think this is a real ladder in terms of your risk of getting COVID-19. Now the question you've got to yourself ask is, how does ocrelizumab, Ocrevus, okay, and its other related drug, rituximab, which is used in some countries to treat MS, how is that increasing a person's chances of getting the infection, coronavirus infection, and then getting the disease, COVID-19? We don't know, but I think I've got an idea. So obviously, to get COVID-19, you have to be infected with the coronavirus. And this is this little red virus here. And everything on the right of this dotted line is coronavirus infection. We now know that a significant number of people, and it depends on your age, it could be up to 50, maybe even higher, get the viral infection but don't get any symptoms. They're asymptomatic. And this is not uncommon with viral infections. You can be infected with the virus and you don't get disease. All right. And then you get mild, moderate, severe, and then there's a small risk of dying from the infection. Now, that risk was quoted in the beginning of the pandemic at being 1 in 25%. We think now it's much lower than 1% in the current second surge. And there's many reasons for that. We now know how to treat the infection, and there's lots of things that have happened. All right. But what you've got to realize, my personal opinion, I don't think people that are on these treatments like ocrelizumab are at increased risk of getting the infection. I think what it does is it reduces the chance of them having asymptomatic and increases the chance of having COVID-19. And I think we're beginning to understand why. And the understanding is that there's now data, there's research showing that if you as an individual have had another coronavirus infection, what you've got to realize is there are many coronaviruses and they run around in our community causing the common cold and upper respiratory tract, sore throats, particularly during the winter months. And these other coronaviruses trigger your immune system to make antibodies and to make immune responses to the virus that possibly cross-react with the coronavirus that causes COVID-19. And that cross-reactive immunity actually protects you and increases your chance of getting asymptomatic disease. And obviously, if you're on an immunosuppressive therapy like ocrelizumab, it may not allow your immune system to make good memory or antibody responses to the other coronaviruses, and therefore reduces your chance of getting asymptomatic disease. And I think this is probably the reason why people on ocrelizumab are slightly higher risk of getting COVID-19 because they don't have good memory responses to the other circulating coronaviruses. Think of this like being a vaccine. Getting the other coronaviruses is like a vaccine, and if you can't make a good immune response to your other coronaviruses, the vaccine hasn't worked, so it won't protect you. And so what happens is your chances of getting asymptomatic infection is reduced, and you're much more likely to get COVID-19. And I think that's probably, and the reason why I think that is because your duration of treatment on ocrelizumab dictates your risk. So it's really people who've been on the drug for more than 3 years, which is an important message. It's not about having ocrelizumab now, it's about having it over many years. So if you are a newly diagnosed person, or you're on another treatment and you're failing, and your neurologist says to you, I want to treat you with ocrelizumab, don't think that's going to put you at risk. It's having been on ocrelizumab for many years that puts you at risk. And so that's why I don't think this changes. I don't think this changes the way we manage MS at all. I think there's nothing you can do about people who've been on ocrelizumab for 3 or more years, because even if you stop the therapy, it takes many years and many months and years for it to reverse its effects. So you can't reverse its action. And therefore, my personal opinion is we continue treating MS the way we should have been treating MS prior to COVID-19. All we're going to advise you is to be more vigilant, more aware of all those things that you've been told to do. Socially distancing, hand hygiene, if you staying at home and avoid visiting high-risk situations, etc. Okay. Also want to point out what came from the Italian, and there were people with MS who died, and it's unfortunate this happened, but this virus can cause severe infection. But the important thing to realize is the people with multiple sclerosis who died tended to be elderly. Most of them were over the age of 60. There were a few in their 50s, but almost all of them, except for a few scatters, a few patients, had progressive disease, and a lot of them had very high EDSS scores. Okay. EDSS of needing walking sticks, wheelchairs. This EDSS 9 is bedbound, and a lot of them had what we call other diseases that put you at risk of severe COVID-19, hypertension, diabetes, everything. And so the message from the patients that had MS who got COVID-19 that died, it looks like the same risk factors that affect the general population predominate in people with MS. It's people who are more aged, more old, elderly, over the age of 60, people who've got more disability, and people who've got comorbidities, other diseases. And so that's the real risk factor, and that's something that you should be aware of. It's not so much having MS, it's having the other risk factors that put you at risk. And as far as we're concerned, the being on DMTs doesn't really change your risk of getting COVID-19, except for long-term therapy with anti-CD20 therapies at the moment. And you can't change that because you've had it. So my message to everybody going out there is, let's treat MS the way we were doing it before COVID-19 came about, and not let COVID-19 be an excuse to reverse our treatment strategies that we've adopted or developed over the last 15 to 20 years and all the lessons we've learned. We shouldn't allow ourselves to go backwards in the way we treat MS. And again, it's all about benefits and risks, and depending where you live, and what you've got to also look at is what's happening in your community. And so if the COVID-19 risk is quite low in your community and you double that risk, it's going to be still low, because my personal opinion is doubling a low risk is still a low risk. And so although it may shift this balance, I don't personally think, based on what's happening in Ireland right now, maybe in some urban areas in certain parts of Ireland, but in general, I don't think the risk-benefit changes a little. It may change very little, but I don't think it changes enough for us to change the way we treat MS. So you can go armed with what I've told you and have a debate with your neurologist if they want to do something different. Okay. At the end of the day, it's up to you as people with MS to take on the risks associated with your treatment, with your disease, and with the potential complications of your treatment. Anyways, in terms of the contemporary management of multiple sclerosis, I'm going to talk to you about how we're managing MS at the moment. So I want you to be aware of antibodies. These are the things that circulate in your blood and in your secretions in your mouth and in your gut that protect you from infections. So just to say to you that there are different types of immunoglobulin. But the most important one to realize is IgM. This is this big one, which has got 5 molecules. Okay, this is the one that comes up first in infections. And then when the infections mature, you start developing very good quality ones, you get IgG. IgA is ones that are secreted into your saliva and into your nose and your gut to protect you against infections. And this may be important for immunity against the coronavirus. And IgE are very important in allergies. So I just wanted to remind you, if you don't know about it, these are the proteins that your immune cells, particularly your B cells, make, okay, that protect you from infections. Okay, and the reason why I say that is because a lot of people now are beginning to worry about when a vaccine comes out for coronavirus, will they be able to make an immune response? And I think the group of agents that our MS drugs tend not to affect vaccine responses a lot, except for 2 classes. The one class is the so-called fingolimod-like drugs. So I don't know if anybody's on fingolimod. The other name is Gilenya. They potentially dampen down your immune response, but not a lot. And there's a new one in the class called saponamide for secondary progressive disease. They may dampen down your immune response to vaccines. The important thing, though, is you still have those vaccines unless they're live viruses, because people have been shown on those drugs to have antibodies. But not everybody makes an antibody level to the right thing. So if you're on that class of therapy, you should still go ahead and have the vaccine when it emerges, because you may make reasonably good antibody responses. It's just unpredictable. The one that's more worrying is the ocrelizumab, rituximab. I've just mentioned to you Ocrevus, and MabThera is the other name for rituximab, because it's been shown to blunt antibody responses. And this is an example of a study in somebody, or in a group of people who have multiple sclerosis that are on these treatments, and they've used the vaccine that's actually made from this mollusk. You may know about the keel limpet. Anyway, it's got a protein called hemocyanin, and this protein is very, very important for carrying oxygen inside the cell. It's like the equivalent of the red blood cell. They use hemocyanin to transport oxygen inside the mollusk. And this particular protein is often used as an example to see if you're able to make an immune response to an antibody, to an organism you haven't seen. And most people haven't been injected with keyhole limpet hemocyanin. So they use this as a test agent to see if the vaccine will work. And as you can see in people in the gray here, people that are on interferon or another DMT or no DMT, okay, when you give them these vaccines, 3 doses, they make a very nice big response of IgM, and that's a big antibody, and IgG, which is a smaller antibody. But people who are on ocrelizumab, they make a little bit, but not much. But importantly, the IgG is pretty depressed. So this is an indication that people who are on this class of therapy will probably not be able to make a good antibody response to a vaccine when it emerges for the coronavirus. And we know that because, yeah, we have an example. This is one case of a person with multiple sclerosis that's been reported in the medical journal. And there are another 2 that I'm aware of, and there's probably a collection of these. So this 40-year-old woman with multiple sclerosis, she was put on Ocrevus in January 2020. And then she developed an upper respiratory tract infection in late March. And she was found to have the coronavirus. So she was diagnosed with COVID-19. And they diagnosed her by putting that swab up the nose and detecting the virus. She was treated with hydroxychloroquine, which we don't use, and an antibody called azithromycin, which we stopped using as well. But anyway, she actually deteriorated over the next week and had to be admitted to hospital with COVID-19 pneumonia. So she developed the more severe type because she went into hospital. And again, she was continued on the hydroxychloroquine. At that time, we didn't know it didn't work. And she was put on another antibiotic just to cover any bacterial infection in her chest. Okay. And she did very well. She made a good recovery and was discharged. So she didn't need to go to intensive care or be put on a ventilator. And then she's fully well in June. What's important, though, is that her immunoglobulin levels were quite low in her blood. But anyway, when they actually measured her blood to see if she developed antibodies against the virus, she didn't. Okay, and she had the test twice. So this is actually an example of a real life person with MS getting coronavirus, getting severe enough coronavirus to get the pneumonia and going into hospital, but not making an antibody response. So this confirms what's happened here, and it makes us realize that somebody on this class of treatment, okay, which affects the way the immune system functions, may not be able to make antibodies in response to a vaccine. So that's my worry going forward. That may not be important because it's not only antibodies that protect you from infection. There's also a thing called cell-mediated. The cells make an immune response. So there are 2 types of immunity. There's cellular immunity and antibody immunity. This blocks the antibody immunity. And this particular person may still have very good cellular immunity and therefore may still be protected from getting recurrent coronavirus infection. And that's the question we don't know right now. That's going to have to be studied for us to be able to say to you. My personal opinion is, regardless of whether or not you're on treatment, if it's a vaccine comes out, people with MS should be vaccinated. Okay, just in case your cellular immunity is responsive and it protects you from getting infection or recurrent infection. I think vaccines are becoming important because it's not only coronavirus vaccines, but it's other vaccines. And I'll give you an example here of one of the vaccines that's quite topical all over the world is the HPV vaccine. So this is the virus that causes cervical cancer in women. It also causes other types of cancer, a small number of cancers of the throat and the esophagus is also due to this virus. And it also causes warts. And at the moment, there are 3 vaccines on the market. And in the UK, the NHS pays for Gardasil 4, which covers 4 strains of the virus. And that only covers about 2/3 of the strains that cause cancer of the cervix. And there's a brand new, well, not that new, there's a new vaccine that actually covers 9 strains of the virus, and it covers about 97% of the strains that cause cancer of the cervix. And it also covers many of the strains that cause warts. And so a lot of people who want to cover themselves against these strains are actually wanting to have the new 9 viral strains. The problem with that is the vaccine has to be given 3 times. There's what I call the initial vaccine plus 2 booster doses. And in adults, that has to be given at month 0 now, 2 months later, and then 6 months later. And then you have to wait a month after the last booster before you can have your treatment. So if somebody wants this, they have to wait 7 months before they get onto a treatment. And somebody with very active MS, 7 months, in my opinion, is too long to wait. So we need to develop strategies where we can potentially give 1 or 2 doses of vaccine and give the 3rd dose later on when they can make an immune response. And so that's a question that is going to become more and more important in this current environment triggered by COVID-19, is that it's making not only the neurologists and the MS nurses, but it's making many people with MS think about vaccines and whether or not they should be vaccinated and when the vaccines happen. So I call it vaccine readiness. And this is a really hot topic at the moment, not only around the coronavirus, but also other vaccines like the HPV vaccine. The next question is steroids. So you all know about steroids. Steroids are often used in MS to treat relapses, okay, to help you recover more quickly. And they're also given to you if you're having an infusion therapy, like ocrelizumab, Ocrevus, or alemtuzumab, Lemtrada, to prevent infusion reactions. And the thing about, and the drug, the steroid we use for treatment of relapses and infusion reactions is a drug called Solumedrol, methylprednisolone. And what the Italians showed, that if a person had Solumedrol, methylprednisolone, in the month, the 4 weeks before they got COVID-19, they were 6 times more likely to have to go into hospital with the COVID-19. So this is actually a very important risk factor for getting severe COVID-19, is having steroids. Okay, and the steroids are not only given for treatment of relapses, but also given for preventing infusion reactions. So what in response to this, we now try and avoid steroids if possible. And I must be frank with you, when it comes to treating relapses, the benefit of steroids is not that great. All it does, it speeds up the recovery of the relapse by about 2 weeks. It doesn't actually affect the overall recovery of the relapse. It gets you, say for example, if you've got a weak leg and it's dragging and you have steroids, that weak leg will recover function 2 weeks sooner than if you didn't have steroids. And so this is why I think, depending on how severe and disabling the relapse is, we're now pushing back and trying not to use as much steroids as possible. Okay. Similarly, with ocrelizumab, the infusion reactions only really occur with the first 2 infusions. When you get on to the 3rd, 4th, and subsequent infusions, people don't get much of an infusion reaction. So we're also now beginning to say, do we need steroids for those infusion reactions? And we're holding back on the steroids to see how they do. And that's quite reassuring to see that most patients tolerate the infusion without any problems. Unfortunately, with alemtuzumab, it's pretty unavoidable. It's very difficult to give alemtuzumab because the infusion reactions are so much worse. And so what we are telling patients with our alemtuzumab treatments, that not only have they had steroids to prevent infusion reactions, but because alemtuzumab also hits the immune system quite heavily, we're telling them to shield for 3 months after the alemtuzumab infusion. Okay. Other things we put in place in our center, and maybe in your MS center as well, we're doing remote assessment of relapses. We've moved away from intravenous to oral in all our patients. We don't need to bring them into hospital to put up a drip. And the reason for that is because hospitals now are a source of infection. We try and make it as safe as possible in our hospital by having a green zone and a red zone and checking patients' temperatures and doing all the things with shielding and everything. But it can't be 100% safe. So if you can avoid going to your healthcare facility, be it a clinic or a hospital, that's better. Okay. And then we're also recommending people shield for 14 days. It may need to be 28 days, but I think shielding is really difficult for people with MS. Stopping your people going out creates mental health issues, etc. So our current advice has been a 14-day, 2-week shield after steroids, simply because that's the incubation period for getting COVID-19. Another thing is some of our treatments lower the lymphocytes, the white blood counts that fight infections. And this has been considered to be a very big risk factor for causing severe COVID-19. I don't think that's correct anymore. And the reason why I say that, there have been lots of cases reported now of people who've got very low lymphocyte counts with MS who've made an unremarkable recovery from COVID-19 without any complications. And this is the most two dramatic cases. This was 2 patients with multiple sclerosis that had been treated with alemtuzumab Lemtrada, which actually reduces your lymphocyte counts down to 0 almost, okay, who got COVID-19. And the one person at 200, just to say to you, we consider a normal lymphocyte count is 1,000 per cubic millimeter. And the one patient had 0 in their things, and they both got COVID-19, swab positive, and they made an unremarkable recovery. So even in our what I would call our most risky therapy, Lemtrada, because it depletes the immune system the most, even people getting COVID-19 have made a good recovery. So I just want people to go away and just say to themselves, hang on, we are not giving alemtuzumab, or people have stopped using alemtuzumab based on a theoretical risk, and we should let the data, the cases and the reports dictate the way we manage. Because of this case report and others, we in our center have gone on to reinitiate our alemtuzumab treatment, starting it and redosing. With precautions in place around warning them about shielding and protecting themselves when they go home. But I don't think we should stop people or deny people access to our most effective therapy, alemtuzumab, simply because there's COVID-19 around. I think we have to treat MS. MS is a bad disease. And as I've shown you, if you get on top of this disease early enough and with highly effective treatments, we really are changing the outcome. And why should somebody with MS now be limited to what treatments they have when they could have got those treatments without any concerns prior to COVID-19? So I think we need to have a balanced perspective on this. Another drug that reduces your lymphocyte counts is cladribine. And recently at our big international meeting, which was done online, we presented 46 cases. And just to say to you, only 4 of these patients required admission to hospital. No patient required ventilation, and there hasn't been any deaths. In addition to these 46 patients who had cladribine, there are a whole lot more. There's probably another 80 or 90 that have been reported to various registries. And the message is the same. Despite cladribine being classified according to various guidelines as being a high-risk drug, the data doesn't support it as being a high-risk drug. In other words, people treated with cladribine who've got COVID-19 have done remarkably well. So another bit of important information. Also, some people will say, well, this data is biased because when you get alemtuzumab and cladribine, your lymphocyte counts can recover. And I'm aware of one particular patient in our hospital in Queen Square down the road who had COVID-19, a mild COVID-19, 3 weeks after their second course of cladribine. And their lymphocyte count was 480, which is below 500, which is meant to be a low lymphocyte count, and they had no problems. So I think the message is also playing out with cladribine is that your lymphocyte count, doesn't matter what it really is, people are making a good recovery. Shielding, so this is a question I always get asked, is who should shield? And I personally think, based on the Italian data in terms of what causes people to get severe COVID-19 and dying from it, I think the people who should shield are the older population. And this is what's recommendations. I think people with MS who are over 70 or over 60 and they've got other diseases, they're overweight, they've got hypertension or whatever, those are the people that would probably shield, or people with comorbidities. Okay. And then obviously people who've got history of recurrent chest infections or swallowing problems. So this would be the MS population, people with MS that are much more disabled, that have got swallowing problems. And the reason you don't want them to get COVID-19 is because they'll be at risk of getting pneumonia and having complications. So I actually think the population is the advanced, older population rather than people on DMTs. I think when it comes to disease-modifying therapy, the people that are most likely to develop complications are bone marrow transplant or hematopoietic stem cell transplant and alemtuzumab. We haven't restarted our HSCT, but we're about to restart it. We've got a few people waiting to have the procedure, and our hematologists are rekindling their service. And alemtuzumab, we've gone back to reusing it now in our center. So I actually even think, even in this population, if you understand the risks of the infection, I think there's no reason why we can't offer people the most effective therapies in the current environment. We also, as I said to you, after high-dose steroids for relapse treatment, we recommend 14 days. And obviously, if you've got symptoms suggested of COVID-19, you have to shield. But that's not for any other reason that you don't want to expose other people in the general population or your family members or anything like that to getting COVID-19. So obviously, that's what we would call reverse quarantine. You're quarantining yourself to protect people outside of outside the home. Whereas the self-isolation or shielding is quarantining yourself to prevent yourself being exposed to the virus. I hope that makes sense. So the other side of the coin is the majority, and I'm talking about the vast majority of people that are active with multiple sclerosis don't have to shield, regardless of what disease-modifying therapy you're on. Okay, it's only a very small number of patients that need to shield in the current environment. Other things that I want to say is that COVID-19 has changed the way we deliver our MS services, and I would imagine it's identical in Ireland. I would imagine you've done the same things we've done as what we've done in the NHS. We've moved to telemedicine, and we now even see new patients on telemedicine, and then we triage them, plan investigations before we see them face to face. We've put in place, I said to you, our online relapse assessment. We're even doing trials online where we're asking patients to participate in new studies where they don't have to come up to the hospital, they can participate. And I'll give you an example of that. And we've also created an online resource so patients can actually go and read about questions and answers without having to contact us and come to our center for it as well. And I think the big plus, and I'm talking about it being a plus because there are always good things that come out of adversary or adverse conditions or these crises, is that it's actually turbocharged people with multiple sclerosis taking control of their own disease and self-monitoring and self-managing their own disease. And this is an important change, is we're giving people with MS tools so that they can take control of their own disease. All right. One of the other things we try to do is change our infusion protocol so people have less contact with ours. So in other words, we've just to give you an example, natalizumab, Tysabri, everybody was on a 6-weekly infusion, and we would push the infusion in over a shorter period of time so that they had less contact with the hospital. And we've also set up things like a home delivery service where you can have infusions in your own home, or your medication is delivered via a courier to your house, and even phlebotomists coming in to check your blood tests. So these are all things that have happened during COVID-19 that are unlikely to be unwound, because some people with MS like the fact that they don't have to come to hospital and come and have follow-up appointments on a video conference, because it saves them enormous costs and effort with transport. Obviously, you can do a lot on telemedicine, but if you do need to see somebody, we can always have a hybrid model. You can have telemedicine, or you can choose between the two. So I think a lot of these changes that we put in place are not going to go away. They're going to stay even after COVID-19 passes, which it will do. You know, in 6 to 12 months' time, this will be history, we hope. But a lot of the consequences of COVID-19 will be with us for many, many years. This is just an example. So this is some of my team. This is Alison, our designer, Professor Schmierer, Professor Baker, and Dr. Marta. And we have this campaign to try and protect upper limb function in people with more advanced disease, simply because up until recently, people in wheelchairs were not allowed to participate in trials, and people were written off once they lost the ability to walk. And we're actually going to be doing 2 trials to try and protect upper limb function in MS. And we had a big campaign around this, which we launched at our ECTRIMS meeting way back in 2016. We even designed a cardboard 9-hole peg test that people can do it themselves at home. And we had a homemade poster, for example, at ECTRIMS to highlight the importance of hand function. And we've now validated our 9-hole peg test. It works as well as our plastic version, which is the one you do in clinic. But what we wanted to also do is create what I call a rehab tool. And the philosophy here is very, very simple. You know, if you're losing function in a particular aspect of your physical functioning, unless you use it, you're going to lose it even quicker. So somebody who's got problems with their fine motor movements in their hand, for example, they can't do buttons anymore, use a knife and fork, unless they continue to doing buttons and use a knife and fork, they will lose that function very, very quickly. And so what we did was we had a little program where we hired a design agency to try and create engaging rehabilitation tools. And they designed things like, this is like a Rubik's Cube, a task for playing with elastics and pegs, tying knots, another game where we use like a dice, etc. And we tested all of these and got people with MS to feed back on them. And we ended up actually with an idea that comes from cross stitch, but it isn't cross stitch. It's a plastic board, and we've called it under and over. It makes people use their hands and having to thread through string through through holes. And you can be very creative. You can actually do text or brains, whatever you want. And this is what it actually looks like with the stitching. And you can do really creative things with it. Anyway, so we call in the stitching for rehabilitation. And this is actually somebody doing the under and over in real time. And this is the little guidebook. Anyway, what we've done is we actually now doing a trial during COVID-19 where we actually take in people that have got upper limb problems, and we're going to ask them to participate in their trial where we'll put them on a waiting list for 3 months, or we will randomize them to immediate rehab, and we'll send them out the under and over kit and get them to do it. And the idea is to see if it can protect or slow down loss of hand function. And so this has all been done without people with MS coming to our clinic. We're going to be posting out the under and over kit to the patient. We're going to be posting out the 9-hole peg test so they can monitor their function. And so this is the idea for this came about quite a while back, but it's very pertinent to the COVID-19 pandemic. Is we're actually doing research in people with MS using the internet and a browser, okay, to see if we can protect upper limb function by giving them a rehab. And we're hoping to make the rehab tool very interactive. And we're going to ask people to be creative. So in other words, create designs. And you may be aware, the National MS Society in the United States created this Face of MS board about, it's probably about 10 years ago now they did it, where each little square here is a face of somebody with a disease. And when you hover over it or click on it, you get their little story. And so what they wanted to do was create a wall, okay, of people with multiple sclerosis, telling their little story. It was part of a fundraising awareness campaign. Well, we'd like to do something similar. We haven't, and what instead of having a wall of faces, we want to have a wall of designs. And we're hoping that if we can get people with MS to engage with this upper limb rehab tool, they'll be able to send in designs and we'll be able to put them up and create a wall of designs so other people can try them. In other words, try and make the tool engaging. In other words, change the patterns they use, make it more creative, make it more difficult potentially, and get people to engage in a community around the rehab. Because we actually think it's very important not to be doing rehabilitation in isolation. You know, doing it yourself is difficult, but if you're doing it with a group of friends and you're competing with each other to get your design on the wall of design, it might make it more engaging. So that's something we want to implement with the under and over after it's been researched. One thing I did do was did a survey via blog to ask people with MS, are they happy with the service change? And we got 95, actually we've had more than 95 responses now, but this, I pulled this down a few weeks ago. And going from dissatisfied to very satisfied, you can see that the majority of people with MS, okay, seem to be happy with the service changes. What is interesting is very few people, okay, only 10% were asked to self-monitor. That's despite us trying to promote it. And only 32% were asked to self-manage. In other words, given advice about bladder management, bowel management, spasticity, etc. So there's an enormous bit of work to be done as to how do we reconfigure our services that everybody gets told how to self-monitor and how to self-manage, or given the tools to do that. Was the virtual consult examination done? Majority of people no. Okay. And was COVID-19 discussed? Yes. So 2/3 of patients reported that their healthcare professional, could have been a nurse or a neurologist, actually had discussed COVID-19. So it's obviously very topical. And was your risk of getting COVID-19 discussed in the consultation? And there was 70% said yes. All right. And then there's this concept called prehabilitation. I don't know if you've heard it. It's not rehabilitation, it's prehabilitation. And this is the kind of thing that surgeons do before they operate on you. They ask you to go out and lose weight or exercise or stop smoking or get your blood pressure under control so you do better with your operation. You're less likely to get complications. And the same thing happens with COVID-19, is that there's things you can do to optimize your health, your general health. So if you did get COVID-19, you're much more likely to get mild disease rather than severe disease. And we know there are a lot of factors associated with severe COVID-19 and death. And there are things that you can do. There are things you can do as an individual. So some of the things that have been associated with poor outcome, you can't change. There's no way you're going to be able to change your age or your sex to change some of the social determinants of health. An example, if you live in a crowded house, for example. But there are things you can do to improve your mental health, okay? If you have low vitamin D levels, there are things you can do around optimizing your general health. And so you can go CBT mindfulness. If you've got disability, you can potentially understand your DMTs. You can go into dietary supplements for vitamin D. If necessary, you can shield yourself. I think that advice probably should be tempered now because there's very little you can do with most of the DMTs and it's not necessary. If you're a smoker, you could stop smoking or go into nicotine replacement therapies. Okay, you have to optimize your management of if you are hypertensive or diabetic or if you're obese. There are things you can do to try and optimize that. And I personally think it's never too late to start because this issue of prehabilitation doesn't only apply to COVID-19. It applies to influenza, flu. It applies to other things. So if you're really serious about improving your chances of surviving infection or outcome, you would take the prehabilitation advice we're putting forward at the current time to apply not only to COVID-19 but to general health. Okay, and after consultation, did you feel reassured about your risk of getting COVID-19? Again, only about 2/3 of patients said yes, so there was still 1/3 of people who still didn't feel reassured. So there is an obvious gap, at least in our service. We're not doing things in a systematic, standardized way, and we're obviously not addressing everybody's concerns. So there's lots of room to improve, and I'm hoping that when we repeat the survey in, say, 3 or 4 months' time, we will have improved the outcome. So I've already mentioned vaccine readiness to you. Okay, so the whole idea, this is the first wave, second, third, fourth wave, possibly a seasonal surge in winter, but we want to cut the tail off of the COVID part by giving you a vaccination. And so, although we're anticipating a vaccine, my personal opinion is in terms of your disease modifying treatment, we should only cross that vaccine bridge when it arrives. Don't plan anything in advance because we don't know what vaccine is going to emerge as an effective vaccine. Is it going to be a live viral vaccine or a component vaccine? We don't know when it's going to emerge. Is it going to be here by Christmas, or is it going to be here by June next year or December next year? And so I think to change the way we manage MS in anticipation of something that may not arrive sometime soon is unnecessary. I think we need to just continue treating MS the way we want to treat MS and cross the vaccine bridge when we get to it. Okay. Anyway, I'm finished. MS is a bad disease. Nothing has changed. And I don't want us to change the way we manage MS. We were really beginning to change the outcome for MS for the better. And I don't want us to go back a decade by changing people onto onto less effective, but in inverted commas, safer therapies. I don't think the data warrants that. Okay. So no change. Okay, I think COVID-19 was challenging this treatment paradigm, but I think the fact that all this data is emerging, we can actually be reassured that there's no need to change the way we manage MS. And I've got to say to you that the risk of COVID-19 is a relative risk, which applies to the general population. I think most people with MS can just consider themselves equivalent to the rest of the population. And I think going forward, we've got creative solutions to delivering a service and doing research, which I think we should keep going forward. And I'd like to thank my team, and I'll take questions.
Great. Professor Giovannoni, that was an incredible webinar and just provided so much reassurance and information to the community. And it just shows that, you know, over the past few months, we really have learned a lot. And I've no doubt that over the coming months, we're going to learn even more. And we have had lots of questions in. I am just conscious of time, so unfortunately, we won't be able to answer all questions. We will try to answer offline any that we don't get to answer now. But if you would be happy to take some questions now, we have plenty of them.
So Diana, can MS cause problem with teeth and abscess? No, in general, that's probably something else. Obviously, if you've got more advanced disease and you've got problems with maintaining your oral hygiene, it could. But unfortunately, people with MS tend to be more common than smokers. So if you're a smoker, you must stop smoking because smoking is a common cause of worse oral hygiene. Okay. Risk of complexities from COVID-19. I've been refused working from home. I'm high risk. I'm struggling to walk with 2 crutches and I'm waiting for ocrelizumab. I can't help you with that. I mean, you'll have to educate your employer about the new data and get your neurologist or healthcare professional to write you a letter in support of your demands of trying to work from home, etc. You know, at the end of the day, it's giving people the information that allows them to make their decisions. HSCT, before we get to HSCT. So yes, am I understanding correctly that I think you misunderstood me. People on rituximab and ocrelizumab will be able to have vaccines, provided they're not live viral vaccines. If they're live viral vaccines, they're probably going to be contraindicated. What I'm saying to you is they're less likely to make immune responses to those vaccines, but we don't know the answer to that because there are 2 types of immunity, antibodies and cells. Almost certainly rituximab and ocrelizumab will blunt the antibody responses, but the cellular response may be maintained, so you should still have the vaccine when it emerges, if it does emerge, okay? So no need not to have it, but just to be aware that you may not respond as well as somebody who's not on those therapies, okay? I stopped using cannabis during lockdown, and after a few weeks, I really felt the effects in a negative way. He started again and really felt the benefits. Did anyone else have similar experiences? I can't talk to that, just to know that cannabis, the active ingredient is tetrahydrocannabinol or THC. That works quite well as an antispastic agent. It also helps with pain, and there's a licensed form of it called Sativex. So we do know it works in MS. The problem with THC is there's no therapeutic window. So the treatment response occurs at the same dose that causes dysphoria or euphoria. So a lot of people don't like cannabis because it causes unpleasant dysphoric symptoms. And also we as clinicians, we never prescribe medicinal cannabis because I don't know what's in medicinal cannabis. We try and prescribe the licensed versions of that. So I don't tell my patients to go off and buy cannabis. I tell them, you know, there are licensed THC formulations that are much better. And I assume THC, Sativex, is licensed in Ireland.
All right, Professor Giovannoni, we've had a few questions in through the chat function as well. So we've actually, we've tried to cluster some similar questions. So if I could just maybe ask you some questions directly, would
Sure.
that be okay? So one of the questions that we've had is, what do you wish your patients would do to self-manage and self-monitor during this time?
So self-monitoring, we're actually phoning our patients and we're giving them advice on how to do their own time 25-foot walk. We're sending them a 9-hole peg test. They've got to fill in a short questionnaire around MSIS 29. So these are the things we have to do every year to monitor if they're getting worse or stable. So it's essentially outcome measures for that. In terms of self-management, there are things you can do to look after your own bladder function and things you can change and diagnose your bladder problems. Similarly with constipation, there are things you can do yourself. Pain, there are things you can do yourself, spasticity, etc. So these are things that you don't have to ask your MS nurse. You can do a whole lot of things before you speak to your MS nurse to try and manage some of your symptoms. Okay, obviously there are things you can't do. For example, prescribe yourself medication, but there's lots of things you can do before you need a prescription for medication. And this may apply to sleep problems, it may apply to anxiety, mood problems. So there are things you can do. In other words, be active in doing this rather than being passive and phoning your nurse and asking your nurse to give you all the advice. Okay, so I think this is going to be what happens in the future. You're going to be asked to do a lot of things yourself first before you actually get to see your healthcare professional.
And that actually ties in quite nicely with another question that we've had in relation to just as the pandemic has gone on, somebody has found that they have less ability to concentrate and have less thinking capacity. And do you have any advice on keeping the brain active during this time?
No, so I mean, one of the things I do is don't ruminate about COVID-19. I mean, this is not the first pandemic and it won't be the last pandemic. And if you want to read people that have been through pandemics before, they're beautiful books to read. You know, there was the Spanish flu, there was the plague, so generations and been through pandemics. So don't, my personal opinion is don't watch the news or read the news all day, every day. Just maybe take your news in once a day if you want to watch the news, and then develop a routine. So, you know, don't stay in bed, get up and be active, you know, and set yourself a routine of being productive. And then also do things that are interesting and different. You know, get out to meet friends if you can, or meet them online if you can. So create I think the most important thing during the pandemic, particularly with people that are quite disabled, is they become very socially isolated. So what can you do to break those social isolation by connecting? Pick up a phone and phone one of your friends every day. I think that's what I would suggest you do. And then read books, watch movies, do puzzles, um, do an exercise program, make it a daily routine to do some exercise. And my personal opinion is, it doesn't matter how disabled you are as MS, there's always something you can do to exercise, even if it's just upper limb exercise. And if you don't know how to do that, try and get physiotherapists to help you. And there are lots of very good online resources from the MS societies of the world, on YouTube, for example, giving you advice about what you can do to exercise if you're more disabled. Exercise is a fantastic treatment for a lot of MS symptoms as well. I don't know if that answers your question.
That's fantastic. And we've had people ask as well about I suppose vitamin D, which you did cover, but just to see if, you know, high levels of vitamin D in people with MS prove for them to have a better experience and outcome with COVID-19.
Well, that's chicken or egg. You see, every bit of, we don't know that because a trial hasn't been done. And what we do know is people with some more severe COVID-19 have lower levels. But we also know inflammation, the cells eat up vitamin D. So vitamin D does go drops with inflammation. So it may be what I would call a reverse causation. The severe COVID-19 causes a low vitamin D. We don't know that, but it's safe to take supplements. I wouldn't take high dose supplements. There are people up there who take 70,000 units a day. No, I would just, my advice has always been the Vitamin D Council. And their recommendation is 5,000 units a day, which is kind of what you would get with about 20 to 30 minutes in the upper body in the sun in a half an hour during midsummer. And so that's not a very high dose, believe it or not. That's a physiological dose, and that's what I take. I take 5,000 units a day, and it's part of prehabilitation. I just want to make sure that I am vitamin D replete. Another thing that you may want to take if you don't have a balanced diet. So particularly if you're on a plant-based diet, if you're vegetarian or vegan, you may be zinc deficient or low zinc levels. And there is some evidence that you need to be, zinc's important for immune function. So I take zinc supplements, but I probably don't need that because I have a really good balanced diet. So that's the only other supplement I would suggest is vitamin D and potentially zinc in people that are on plant-based diets and not getting or not taking enough. There are some, I've forgotten the list, but there is a list of plants if you're vegetarian that you can take that are high in zinc. But some people are. We just did know that vegetarians, when you measure zinc levels, are lower than normal people.
Great.
Okay.
So I'm just going to leave it at two more questions, just being mindful of time. So one is in relation to vaccines, and what is your opinion in relation to vaccines such as the pneumonia or the flu vaccine?
Yeah, well, the flu vaccine has been studied many times, and in general, it hasn't been shown to trigger relapses or MRI activity. And it's a component vaccine, so people should take the flu vaccine as recommended. You're at high risk, and people don't want to get flu because flu can really knock back people with MS, particularly they've got disabilities, really badly. So please go ahead and have the flu vaccine, definitely. The pneumococcal vaccine, which is the Pneumovax, should be everybody going on to an immunosuppressive therapy, which is all of our treatments really, except for interferon beta and glutathione acetate. All the other therapies are classified as immunosuppressive, should have the Pneumovax before starting, and then there's an annual booster for that. And that's to protect you from getting pneumococcal pneumonia. And we know that pneumococcal pneumonia can be very severe and it kills people every year. So this is just another preventative strategy. So everybody should have their Pneumovax done before they start the treatment. We'd recommend that. To be honest with you, people with multiple sclerosis should have all the vaccines they're eligible for. The only one they've got to worry about are live viral vaccines on certain treatments. They can't have that because the virus could potentially mutate back into the virulent virus and cause a major infection. And so you should avoid live viral vaccines if you're on certain treatments. And I think you need to ask a neurologist about those treatments.
Okay, and then the final question, Professor Giovannoni, is in relation to the clinical trial that was done and the MS patient who flared on that trial, and if you feel that it might be risky for patients, for people living with MS, to take that vaccine as soon as it comes out, or should they hold tight for a little while?
I think it's too early to say. I think we need to look at the data shows. I mean, all we know is that one person developed MS on they probably had old lesions, so this may have been the vaccine triggering it, or it could be coincidence. And the other one got a transverse myelitis, inflammation in the spinal cord, which is a common problem with lots of vaccines. It's not unique to any particular vaccine. But I think we need to see if that's going to reoccur. Just to say to you, there's been a large number of people reported with transverse myelitis who've had COVID-19 triggering transverse myelitis. So it may not necessarily be the vaccine, but it may be the actual infection, the protein that is used in the vaccine. And if that's the case, then it's going to be a risk for all the vaccines. So let's wait. My personal opinion is at the moment, it's far too early to say if this vaccine is going to be safe or not. Let's wait for all the data to come in, and then you'll see if there's a risk of transverse myelitis or triggering relapses. We may get a signal if not, then people have got to be aware there are no vaccines that are safe, 100% safe. It's all about the benefits, the potential benefits versus the rare risks. And the thing about vaccines, they're not always about you as the individual. They're about herd immunity. So you go into the vaccine knowing that it's also about protecting the wider society, in other words, stopping the virus spreading. And so my personal opinion is as many people should be vaccinated if the vaccine comes available as possible, because we need herd immunity. And the herd immunity is to protect older and more vulnerable people in our society. And that's the thing about vaccines, is a bit of altruism there. You go into them not necessarily knowing if it's going to benefit you as an individual, but it's at least going to benefit the larger society.
That's wonderful. Well, just being mindful of time, Professor Giovannoni, we might leave it there with the questions. Thank you to everybody who submitted a question. Thank you to everybody who has joined us. Thank you especially to you, Professor Giovannoni, for your time and for your expertise in providing so much valuable information to our community. We really appreciate you taking the time to do it for us.
Pleasure.
Thank you. And thank you again to Novartis for their support with this webinar. If the recording of this will be made available on YouTube in the coming days, so if anybody would like to rewatch it or revisit it, it will be available hopefully by the end of this week. Thank you everybody for joining us this evening, and we will share information on our next webinar on our website soon. Thank you.
Take care. Bye-bye.
Bye.